Hello, everyone. Welcome to our second session of COVID-19, Colorado and Beyond. This webinar is sponsored by the College of Liberal Arts and Sciences at the University of Colorado, Denver, and its programs in continuing and professional education and interdisciplinary studies. My name is Marjorie Levine Clark. I'm a professor of history and associate dean for diversity, outreach, and initiatives in the college, and I'm your moderator for the series. If you missed last week's excellent lecture by Dr. Jonathan Samet, it's available on the CLAS YouTube channel. All lectures in the series will be posted 2 or 3 days after they're delivered, so if you missed something, you can always catch up. You should have received the YouTube link in your reminder email for today, and you can find it on the Continuing and Professional Education website where you enrolled. Please use the Q&A feature at the bottom of your screen to ask questions during the lecture. We will collect questions and hope to get to as many of them as we can at the end of the presentation. Information about student credit and continuing education units can be found on our Continuing and Professional Education website. Students interested in credit have to write a one-page paper for every lecture. Today's prompt for your paper is: describe 2 or 3 key potential sources of misinformation about SARS-CoV-2 or COVID-19, some strategies for identifying and avoiding that misinformation, and why it is important to do so. I'm going to repeat that. Describe 2 or 3 key potential sources of misinformation about SARS-CoV-2 or COVID-19, some strategies for identifying and avoiding that misinformation, and why it is important to do so. The prompt will also be posted on the website, so no worries if you can't write it all down now. Okay. Many people have been involved in making this series happen, and I would like to thank them here. First, Dean Pam Jansma and Assistant Dean Joanne Porter of the College of Liberal Arts and Sciences for supporting this program and making credit available to many of our students at no cost. Our outstanding faculty who volunteered their time for this series: Mike Effler and Noah Dodero from the Office of Information Technology, Shana Bull, Amy Arnold, and the Office of Digital Education, Interim Associate Vice Chancellor of Academic Affairs, Joanne Brennan, the University Registrar, Carrie John and her team, Associate Bursar, Eric Gray, Tracy Combe, Director of Marketing and Communication in CLAS, Laurel Dodds, Director of Continuing and Professional Education in CLAS, Course and Curriculum Coordinator Mary Lovett in CLAS, and finally, Kristen Salisbury, Program Manager for CLAS Continuing and Professional Education, who coordinated putting this whole event together under an extremely short timetable. Our lecturer today is Dr. Jimi Adams, Associate Professor of Health and Behavioral Sciences. Professor Adams received his PhD in sociology from Ohio State University. His work focuses on how social networks promote or constrain the spread of things like diseases and ideas through a population. His lecture, which sounds like something we all need to know, is titled "How to Avoid Misinterpreting Data About an Epidemic." Welcome, Dr. Adams.
Okay, so this session is going to focus on how we can avoid misinformation or misinterpreting data about a pandemic like the one we're encountering currently with COVID-19. And in order to do this, we're going to start out by motivating why it's important to avoid misinformation in the first place. Then we'll dive into how to avoid it, particularly focusing on understanding some of the common measures that are important for interpreting epidemics and highlighting some of the ways that those are frequently misinterpreted. Then diving into accounting for the ways that models serve different aims when they study epidemics, and recognizing that when we evaluate those models, we should do so according to those differing aims. And then finally, we'll talk about how expertise can serve as a means for navigating all of the information that's available to us. You, at some point, may have encountered this quote from Mark Twain, that's attributed to Mark Twain, I should say, where he said something to the effect of, "A lie can travel halfway around the world while the truth is putting on its shoes." Or you may have encountered a similar quote from Winston Churchill, but the punchline is that neither of these people actually are documented as having said what's attributed to them. And there are other sources going back even centuries before that, including to Thomas Jefferson and others. The point here, though, is that misinformation is pervasive, and ironically, even misinformation about the sources and consequences of misinformation is common. So if we're going to spend our time trying to avoid misinformation, you might be asking yourself whether we shouldn't just correct it instead. And I'm going to point out that there's a relatively robust body of literature demonstrating why this is a difficult task. And I want to highlight just a few selections from that literature. And the first is that we're currently encountering what the WHO and others have referred to as an infodemic, which is essentially an overwhelming amount of information that we would be attempting to navigate. And more generally, correcting misinformation can be difficult because of a variety of other reasons. One is what is referred to as the illusory truth effect, which suggests that the mere exposure to misinformation can increase our belief in its truth. A separate body of literature, particularly arising from political science, is around what is referred to as the backfire effect, which suggests that in the very act of confronting misinformation with attempts to correct it, we can inadvertently strengthen one's prior beliefs in that misinformation, having essentially the exact inverse effect the correction was attempting to have. I should point out, however, that the backfire effect has relatively mixed evidence in the literature. Particularly kind of different domains are seemingly more susceptible to it, and that attitudes are more likely to backfire against corrections than facts are, or said another way, facts are more adjustable than attitudes are. And another reason that misinformation correction is particularly difficult is a limitation of the way our memory works. And what you can see here is this is a study going back decades that suggests that people have a difficulty remembering negative statements, and we tend to remember them as positive. To illustrate this example, here's an experiment from more recently where people were essentially asked to remember items that they were explicitly told as being true or being present, another list of things that were explicitly told as being absent or false, and then there was a list when they were tested on their recall of those two lists. There was another list inserted of things that weren't explicitly mentioned. And what you pick up here is that over time, as there's more time between when you hear something and when you try and recall that information, people increase the amount with which they forget the negations of statements. So, for example, if I were to tell you today that hydroxychloroquine does not provide benefits to those with COVID-19 or protecting people from getting COVID-19, in a week from now or more time after that, you would be approximately double, you would be approximately twice as likely to remember that I said that it is beneficial than not, as you are today. And that kind of ability to remember those negations reduces as time progresses. And so if correcting misinformation is so difficult, we also probably want to ask, does exposure to misinformation actually lead to implications for something like COVID-19? So here's a paper that attempted to estimate this, where in the gold squares, what this is illustrating is two different groups' differential exposure to amounts of misinformation. And you see that differential exposure kind of peaked in mid-February when they were experiencing the most differences in the amounts of misinformation they encountered. And then it declined to the point that by mid-March, these two groups were essentially getting the same quality of information, if you will. But then we can compare that exposure to misinformation to the effects on the number of COVID cases and the number of COVID deaths, the difference in those numbers between these two groups. And what you see is essentially an echo of the misinformation in a very similar pattern in the number of cases and the number of cases about a month later, and then the number of deaths about 2 weeks after the number of cases, in the group that was exposed to more misinformation, having about 30% higher number of cases and number of deaths than those who were exposed to less misinformation. So misinformation matters. Therefore, it's important for us to avoid misinformation because it can help us filter what's worth paying attention to. Misinformation can be hard to replace. Misinformation can shape behavior and outcomes in detrimental ways. And so while it may not have been Winston Churchill or Mark Twain who said it, the best way to deal with misinformation is, as their quote would indicate, to get out ahead of it. So I mentioned the notion of an infodemic previously, but I want to give you a little bit more detail on it here. In epidemics and pandemics, the WHO and others have indicated that an infodemic leads to the overabundance of information, some of which is accurate and some of which is not, that makes it hard for people to disentangle the truth from the falsities. And it makes it also difficult to find trustworthy sources and reliable guidance on how to respond. And the WHO particularly highlights that this has impacted kind of a range of topics within COVID-19, including the cause and source. I'm not going to talk about that one in particular here because I know you get a session on that later. I'm going to focus more on some of the transmission elements, and we're going to talk in particular about R0, flattening the curve, testing, and fatality rates, all of which are concepts you may have been encountering more in the past couple of months than you had previously. So we want to address making sure that our understanding of each one of these is appropriate. R0 is formally the reproductive rate of infection, or another way to think about what that reproductive rate means is it's the number of new cases expected to be generated on average by each existing case amongst a fully susceptible population. And so what you see illustrated here at the bottom is that each person generates 3 additional cases at each generation. So this person then generates 3 new cases and so forth and so on. And the other thing that's nice about R0 is it also can tell us something about kind of the efficacy of interventions in reducing that onward spread. So what R0 really tells us is an estimate of the growth rate of new infections. Something that is more implicit in the way it's commonly talked about, but is explicit when scholars deploy R0 is that it is the product of 3 different elements. One is the duration of infectiousness. So in order to understand how many new cases each one would produce, we need to understand how long an individual who is infectious or who is infected remains infectious. How long can they pass it on to others? We need to understand the rate of contact between those who are susceptible and those who are infectious. And we need to understand the likelihood of transmission. So how likely is it that when people who are susceptible come in contact with those who are infectious, how likely is it that a transmission occurs? And R0 is a product of these 3 factors. So that's what it is. It's also important to understand a little bit about what it doesn't tell us. And R0, one of the primary things that's important in this moment to recognize is that R0 does not tell us the extent of the final outbreak. Assuming R0 tells you the size of the final epidemic would be like assuming that knowing your car's current acceleration would tell you the destination of your trip, right? It just doesn't kind of come out. All it tells us is how fast things are increasing. It's also important to recognize that because of the 3 things that are, it's a product of identified above, is that R0 is not solely a feature of the virus, but instead it combines things that are kind of socially, biologically, and culturally differ across societies. And as a result, it varies across subpopulations. Or said another way, R0 is not a feature of the virus alone. It's a feature of the virus as it intersects with social and cultural factors. So a second concept you've probably heard more over the last few months than you had ever before is that of flattening the curve. And flattening the curve is illustrated in this graphic on the right here that essentially says that what we want to do is reduce the number of cases we're encountering at any moment in time so that we can manage our capacity for our response, particularly to avoid surpassing the capacity of hospitals and the number of beds they have available. But what may not be clear immediately when we talk about flattening the curve, but is fundamental to its principles, is that without other interventions, flattening the curve will not necessarily reduce the number of cases. And it is designed to actually elongate the duration of the outbreak. And these sometimes might seem counterintuitive to people who think that flattening the curve is going to be useful for reducing the effects of an epidemic. We might think that both of these would be key features. But the reality is what it gives us is time so that other interventions can accomplish this reduction in cases that we would want, or a reduction in the severity of consequences for those who do get infected. And so while social distancing and mask wearing and hand washing are key components to flattening the curve, these need to be complemented with things like expanding treatment capacity or developing new treatments or preventatives. A third concept that you probably have been thinking about more recently than is often the case is how testing works for identifying infections. And what I want to point out here is there are actually there are two primary different types of tests that are available for COVID-19, and I think you're going to get a little bit more detail of this one as well in a later session in this series. But for now, I want to highlight the difference between what are referred to as diagnostic tests and what are referred to as antibody tests. But a diagnostic test aims to detect current infections, and it's typically conducted with a swab of the respiratory tract, as illustrated here. A serologic or antibody test, on the other hand, tells you whether you've had a previous infection. So these are testing for different things. Are you currently infected is diagnostic, and could you then pass it on to others? A serologic test is asking if you've been tested previously, and as a result of that, do you have antibodies or protection? And the other things noted here are simply some of the labels that are used for those various types of tests. I'm not going to go into the details, but just so you know which are which, I wanted to provide those for you here. So since those tests have different aims, they're useful at different times. And this is an illustration from a paper in JAMA that was released about a month ago, where they show that if you look at the blue and the pink colored curves here, the ability to detect a positive case with PCR or other forms of diagnostic testing only really lasts through about a little over 3 weeks post symptom onset, whereas antibody tests pick up those who have been infected much longer than that, but they don't start to be possible until approximately 2 weeks after symptom onset. So this is saying that the ability to identify a case is going to be different according to these tests, depending on when we give those tests compared to when the person was infected and or when symptoms were onset. Another thing that's important to point out from this slide is it's still unclear how long the antibody-based resistance that we would be picking up with an antibody detection test or serological test. It's currently unclear how long that lasts, and that's an open question still in the literature. Another detail about testing that is important to recognize is we often want to know how accurate tests are. Are they giving us accurate information? Well, the reality is in tests for infections, this accuracy question is actually two questions in one. The first question is what is known as sensitivity, and sensitivity tells us the probability of a positive result given that somebody is infected, or is the test sensitive to the results. So you can look on the left side here and basically saying, if all of these people are infected and only these people test positive, then all of these people outside of that circle are what we would refer to as false negatives. And so this would be, particularly in a diagnostic testing condition, this would be failing to recognize people who are currently infectious and could pass the disease on to others. Another question of testing accuracy is what is referred to as specificity, and specificity indicates the probability of a negative test result given that there is no infection. right? So is the test specific to this particular virus being tested for, or is it picking up other things as well? So on the right-hand side here, you see all these people who are not currently who have not been infected with SARS-CoV-2, and the ones outside the circle test negative, so that's accurately negative, and then the ones inside the circle test positive even though they are not positive, right? So these are what we would refer to as false positives. And false positives can be particularly impactful on this antibody test. If people think they have been infected, they might assume they have protection from the antibodies when they were not. So tests that have low specificity can be problematic in that way. Generally, the patterns have been that for SARS-CoV-2, the patterns have been that specificity on most tests has been higher than sensitivity. Antibody tests are more sensitive and specific than diagnostic tests. And ELISA, one of the kind of longer duration tests for antibodies, tends to be more accurate, more accurate than rapid versions of those tests, particularly with respect to sensitivity. So a final concept that I want to talk about with respect to COVID-19 is the fatality rate. So it's important for us to know how lethal something like COVID-19 is, because it contributes to what a proportional response or what we want to do to react to it would look like. So we want to be able to answer how common COVID-19 attributable deaths or fatalities are. And the fatality rate from COVID-19 is a simple kind of fraction of the number of deaths in the numerator divided by the number of people who are at risk in the denominator. But it's not as clear as this might seem of both what goes into the denominator and how accurately we're able to count the numerator. So I want to illustrate this for you with 5 different variants of fatality rates that you may have encountered at various times in your reading or learning about COVID-19. As of June 10th in Colorado, we have reported confirmed 1,573 deaths of those who are COVID-19 positive. And so we want to then ask who's in the denominator to calculate a fatality rate from this number of deaths. Ideally, we'd like to be able to calculate this amongst the total number of people who are infected, but as you're probably aware by now, we don't often have a good estimate of what that number is. I'll loop back to this in a second. So what we typically end up estimating instead is the CCFR, or the fatality rate amongst those who have confirmed cases. So who's tested positive for COVID-19. And if we do that with the numbers from June 10th, we'd find that there are about 28,500 people who have tested positive, and this gives us a confirmed case fatality rate of about 5.5 per 100. But that's not the only alternative we have. For a long period of time in our experience with COVID-19, we weren't testing everybody. We were only testing those who have symptoms because testing capacity was low. So we were working with what gets referred to as a symptomatic confirmed case fatality rate. And what we should recognize is that this CCFR is going to have fewer people in the denominator because we're testing a smaller proportion of the population, and therefore the fatality rate is going to be estimated to be higher than when estimated as the CCFR. Alternatively, what is often referred to in the epidemiologic literature is what is known as the case fatality rate. And the case fatality rate here includes all presumed cases, both those who are confirmed and those who are suspected to be positive in the denominator. And so as a result, this is going to have a much larger denominator than is true if we relied only on confirmed cases, which is going to lead, therefore, to a reduction in the fatality rate that would be estimated from these. And this can lead us back to answering the question of kind of what we think the IFR is. And many of the estimates currently in Colorado suggest that we are picking up, we're confirming cases at a rate that is lower by a factor of about 2 to 4 from the actual number of cases. Or said another way, the number of actual cases in the population is probably somewhere in the range of 2 to 4 times the number of confirmed cases that we've identified at this point, which would lead us to estimate that the infection fatality rate in Colorado is somewhere between 1.4 and 2.8%, which is comparatively high to other places So there might be some adjustments that need to be made in some of these other data. But all this to say, different versions lead us to different conclusions. And one of the recognitions that has kind of long been advocated for amongst demographers in particular is, since identifying those cases is so problematic, another way we could do this is we could try and avoid having to estimate the denominator altogether. And that leads them to refer to what is sometimes referred to as the cause attributable mortality rate. And this is saying we're going to take the number of deaths that we observe, and instead of dividing it by the number of cases we think we have, we're going to just divide it by the entire population, right? And so in New York State, this number has been increasingly been the one that is reported on, showing that more than 1 in 1,000 New York State residents have died as a result of COVID-19. Here in Colorado, that number is much smaller, in the range of 2.7 per 10,000. An additional point to highlight here is that our ability to estimate each one of these has changed over time. So, for example, more people are being tested today than were being tested earlier in the pandemic. And so our ability to estimate the case fatality rate the denominator in that has gone up substantially, reducing the overall fatality rate estimated by the CFR. So these aren't going to be the same. While we have 5 kind of different measures at any one point in time, each one of those measures and our capacity to estimate it has changed over the course of the pandemic as well. All that to say, when you hear fatality rates estimated in the literature or in newspapers, et cetera, you should understand which one is being reported before you try and compare them across locations, et cetera. And it may seem as though while the denominator is hard to estimate, you may be assuming that estimating the numerator is easier. Well, how do we determine deaths that are attributable to COVID-19 is an assumption that goes into the calculation of that numerator. And we could start with just anyone who's had a positive test as indicating the number of deaths, anybody who's died with having had a positive test for SARS-CoV-2 is one way to calculate it. Another way, and Colorado reports both of these now, is that there can be people who die with SARS-CoV-2 who don't die because of COVID-19. For example, if somebody were to die in a car accident, COVID-19 would not be the cause of their death, even though they are positive for the infection. And so we could report in that numerator only those who die particularly from COVID-19. We could also recognize that the ability to estimate either of those is hampered by our ability to have confirmed tests. So we might allow for those who have presumed positive status to be in the numerator instead of only those who are confirmed cases, depending on our interpretation of depending on our aims for interpreting this fatality rate. And a final way that this has been explored is by examining what are referred to as excess deaths, which I'm going to illustrate in more detail in the next slide. So what excess deaths asks is essentially, it takes the observed number of mortality, the observed number of deaths over some period of time and compares those to the average in that same period of time in previous years. So we know that there's seasonality to deaths. People are more likely to die in certain times of the year than others. And so we want to account for those differences and then compare what's going on today with what's going on with that historical record. And what we see in Colorado is based on the expectations derived from, I believe this is a 5-year moving average. So compared to the last 5 years, we've seen in the period from March 15th to May 16th, so in 2 months, we saw about 1,600 more deaths than we would have expected from the previous year's information. And what we can then do is look at that across locations, or also we can look at how how COVID-19 deaths are accounting for the proportion of excess deaths that are observed in a locale. And what this may provide an indicator of is the rate at which we are undercounting the number of COVID-19 deaths. So in New York City, for example, there have been reported 2,500 COVID-19 deaths through April 4th, but they estimate that they had about 6,300 excess deaths in this time, which is a gap of 60%. This isn't necessarily suggesting that 60% are all COVID-19 deaths that have gone undetected, but the truth of kind of how many COVID-19 deaths have actually taken place in that location probably is somewhere between this 2,500 number and the 6,300 number. So you might be asking, what is the corresponding rate in Colorado? Well, our COVID-19 deaths have accounted for about 75%, or about 1,200 of those 1,600 excess deaths. So to kind of sum up what we've talked about in this section, is we've highlighted a number of measures that you've probably been encountering or thinking about more frequently than you ever had before. You've been thinking about them more recently than you ever had before. And I wanted to highlight a number of things that those do indicate, and then also illustrate a few things that they are sometimes misinterpreted as indicating. And in particular, R naught is something that varies across outbreaks and doesn't necessarily predict the extent of a final epidemic. Flattening the curve, as you've, I'm sure, heard by now, aims to not overwhelm medical care capacity. But in doing so, it can actually make an outbreak last longer. And so what it is really doing is allowing time for other interventions to step in and hopefully reduce the number of cases and or the severity of cases that do occur. Diagnostic and serologic testing have different aims and different capacities, and we should recognize that. Fatality rates are fundamentally hard to estimate and rely on information that is not particularly comparable. And so we should recognize the differences between them and recognize that the information we need to estimate them changes over time and changes in quality over time. So the hope is that when you're reading new updates in the newspaper, hearing things in other sources, you now have a little bit more information with which you're equipped to know how to interpret these types of these concepts, and when not to compare their estimations. So what I want to move to now is talking about models. This is a quote from a statistician named George Box, where he points out that all models are wrong, but some are useful. This is because what models are is a simplification of reality that allows us to draw our attention in a focused way to particular aspects of what's going on in the world. And so essentially what we should recognize is that models are useful, but what are they useful for? And this leads us to point out that COVID-19 models generally have three different flavors that are all asking fundamentally different questions. And so I want to break those down for you here briefly. The first is what is referred to as an explanatory model. And an explanatory model, what we're trying to do is account for details of what has already taken place. We can focus on outcomes, like, so why do we see the number of COVID cases we do, or exposures, how different risk factors can lead to different levels on those outcomes. And so a common thing that you're hearing reported probably more recently is that there are large racial disparities in COVID-19, both in cases and in the severity of those cases in terms of kind of the number of deaths that they lead to, or other complications that can be brought on by other kind of disparities that already exist in the healthcare system, or racial discrimination, et cetera. And so what this slide illustrates is, let's highlight the gray bars first. The gray bars are the proportion of each racial or ethnic group listed here in the population of Colorado as a whole. So this shows that there's about two-thirds of Colorado's population is non-Hispanic white. About 20% of Colorado's population, about 21 or 22% of Colorado's population is Hispanic, combining all races, and about 5%. About 3% of the population of Colorado is African American. And then what you see corresponding in the red and the blue bars blue bars is the number of COVID-19 cases in that racial or ethnic group, and then the red bars is the number of deaths in that group. And so there's two disparities in particular here I want to highlight for you that this data reveals, and that is Latino members of the Colorado population are much more likely to get COVID-19 than we would expect given their representation in the population. So while they represent about 21 or 22% of the population, they represent about 38% of the COVID-19 cases. And while these numbers are small in their absolute size, the comparisons here are substantially disproportionate for African Americans in Colorado, in that African Americans represent about 3% of the population on a whole in Colorado, but they represent about 5% of the cases and about 6% of the deaths from COVID-19 in Colorado, suggesting that African Americans are at a higher risk and a higher consequence of COVID-19 consequences than are whites in Colorado. So a second type of model is what get referred to as projection scenario models. And these are predictions about what researchers expect would happen under certain hypothetical conditions. And what I want to point out here is these are not predictions about the future. These are predictions about if things were to happen in a certain way, what we would expect to happen. So these are useful tools, particularly for policy development. We could start from a baseline of saying, if we made no intervention, what would we expect to happen? And then if we made certain types of interventions, how would we expect those outcomes to differ from that baseline scenario of no intervention? And so last week, John Samet talked to you briefly about, in some detail, about the work that our team has been doing, the team he leads has been doing on modeling scenarios for Colorado in ways that have been informing decisions at the policy level. And this is one such kind of projection scenario where we're asking what would be the number of ICU beds needed under certain conditions of social distancing that are reductions from if we currently estimate social distancing to be about 75 or 80% in Colorado, if we reduce that to certain levels, what size of an epidemic would we expect, and subsequently, what would be the corresponding ICU bed needs based on those outcomes. And the dashed line here indicates the current capacity in Colorado. So you see for most of these scenarios, if we reduce social distancing to these kind of lower levels, we would surpass that ICU capacity, which would lead to severe problems in terms of the complications that people encounter as a result of their infections. So the third type of model is a forecast model. So this is saying, what do researchers actually think we are likely to experience? And there are a variety of these out there. I think the best of the bunch is work that is done by Nicholas Reich in his lab at the University of Massachusetts, where essentially they're taking a combination of models and putting together predictions of what they think the future is likely to look like. And one of the things I would point out with this particular model is what they're doing is aggregating across a lot of models to make a single prediction. And inside those individual models, there are different predictions. So you see here one that is predicting that we're likely to see the number of deaths from COVID-19 to go up in the immediate future, while the rest of them are predicting it will go down. And so this is a type of model that is asking what we think the future will actually look like. If you've been following what's going on in models at all, you may have observed that they have a tendency to change with some frequency. And some people have used this to criticize modeling as though it is problematic. But the reality is we would expect models to change because science is intended to learn from new information. And as we gain more information about how the virus spreads or about differences in efficacy in different locations, so if we're in contact with others outside versus inside, it seems there's a different rate of infection, a higher rate of infection inside than outside from those exposures, then we should learn from that and incorporate that into our models as time progresses. So models differ in their aims. Explanatory projection and forecasting models really are intended for different purposes. And therefore, it's inappropriate to compare across models that have different aims or to evaluate a model that's trying to do one of these things based on the standards of another. And the other thing we want to take away from this point, this section, is that science really is iterative. It's not static. We should learn from new information. So with the remaining time, what I want to briefly touch on is how we can rely on existing sources of information to help in our ability to avoid misinformation or to fight an infodemic. And the first recommendation is that we should vet our sources. We should make sure that the places that we are getting information from are reliable and can be expected to provide useful information. And I'll dive into this in some more detail in a couple of slides. Another thing that I want to point out with respect to this is that there are experts. And why I feel like I have to say this is because COVID-19 is new, there have been a lot of people who have at times suggested that in its newness, there aren't people who have experience with it, and so therefore we're all kind of wandering around trying to find new information as it comes. And this really is an overly glib statement of reality. There are experts. There are experts who can provide information based on a prior knowledge of similar outbreaks or diseases that spread in similar ways or virology that looks similar at the kind of cellular level. We can learn from the expertise that we've developed on other viruses and apply that to COVID-19, and we can update that as we learn more about COVID-19. Or said another way, since coronavirus has so much information out there, it's really important that we're able to evaluate information based on prior expertise. Another thing that is useful for thinking about kind of sorting through the variety of sources that are available is you simply asking yourself how accurate information seems as you encounter it. You may have noticed late last week that Twitter was suggesting a new policy where they were basically going to ask people to indicate whether or not they've read an article before they share it. And you might wonder why in the world they would do that. Well, this is actually based on scientific evidence, where the simple task of encouraging someone to consider the truthfulness of something they have encountered reduces their likelihood of sharing misinformation. So just that little nudge of asking people to consider how useful they think information is can reduce their likelihood of sharing it if it's problematic. Another thing that should be important is an important consideration in evaluating and finding credible sources is seeking confirmation. Just because you read something once doesn't mean you should assume that it is accurate. Multiple independent sources can be a useful way to reduce the likelihood of being susceptible to false information, and this is a bedrock principle of science. Science is an ongoing, replicating, iterative, self-correcting process. We learn from new information within science. And then finally, the last thing I want to suggest is finding a body of existing experts upon which you can rely to get reliable information about COVID-19. And some of the things you should look for to help you identify when experts are likely to be useful are those who have domain expertise. So infectious disease epidemiologists are a great place to start. But there are other people who have also kind of domain-specific expertise that is useful for interpreting what's going on with COVID-19. From the range of sciences, all of them have something to contribute here. But it is important for us to, when we're looking to that expertise, to look to those who are clearly indicating what their work does and does not apply to with respect to COVID-19, and not having people kind of extend beyond the capacities of the work that they're reporting on. Good science will always make their assumptions explicit, so people who are hiding assumptions is something you should avoid in interpreting the veracity of their claims. And good kind of science and or science reporting will provide the details of the data that they're using to reach their conclusions and the sources from which they build ideas. So one of the common kind of ways that misinformation gets perpetuated on social media is someone will say something to the effect of science claims or experts believe, and then they'll provide no link to where that science is or who those experts are, and that should be an immediate red flag for you. Another thing that experts will rarely do is overstate their confidence in their claims or make kind of grandiose, broad, sweeping claims. Another way to say this is you should recognize that people, when they are providing limitations on the expansiveness of the claims they are making, that should be a positive sign for you in interpreting their expertise. And there was a great piece on this in Wired about a month ago on why qualified and cautious information interpretation should be a positive sign for you in identifying expertise. And scientists have to acknowledge their limitations and where we're uncertain. And most scientists are more than willing to do that, but this should be another thing you should be on the lookout for when you're looking for sources to rely upon. And I've compiled for myself a set of sources that I've been relying on a lot with respect to COVID-19, and that's available online if you might find that interesting. These are Twitter streams that have been particularly helpful for myself. So in summary, misinformation really can have negative effects, and so our aim should be to build some strategies to avoid it. And one of the key ways to do that is knowing what key concepts mean, and that can help to limit our susceptibility to misinterpretations of them. We should recognize that science is iterative. We're going to learn new things, and it has different aims. So we need to base our evaluations on what the types of questions are that any science is attempting to address before reaching any conclusions about its utility. And lastly, there's a lot of information out there about COVID-19. And so being able to navigate it is not something that all of us can do. In fact, it's not something I have the time to do, even though this is a focus of my research these days. So what we have to do is we have to find reliable sources that we can consistently rely upon, and then developing strategies for identifying when other sources are or are not likely to be accurate. So thank you.
Well, that was really interesting, Dr. Adams. I thoroughly enjoyed hearing, I mean, from a historian's perspective, thinking about misinformation is really fascinating. So we had some questions come up along the during the lecture, and I'm going to take them in the order that they came. And I have some questions. So one is about the disease itself in relation to testing. How long, I think I kind of paraphrased this, but how long do antibodies last? And related to that, could people become infected again? Do you have ideas about that?
Yeah, this is a really important question. I want to flip back to the slide where I was talking about that. Because the short answer is that we know that antibodies develop, and we know that they provide some level of protection from re-exposure. But how long that lasts is currently an open question. We don't have a clear indication of yet kind of how long that's going to last. And so, yeah, I think that the best way to answer that is to say it's an open question that attempts to answer right now would really be stretching beyond the data that we actually have. And so the other thing I would say with respect to that is you may have read a number of news stories at various times that have made claims about kind of reinfections already taking place. And the follow-ups to every one of those studies that I've seen have been that people were testing positive for remnants of prior infection. There wasn't a new infection taking place. So we don't have any evidence yet of people becoming reinfected. But the way many viruses do work is that eventually immunity does wear off, and we do potentially have resusceptibility. But what that time frame is has not been kind of identified yet with respect to COVID-19.
Okay,
I think that's everything I was going to say on that.
Okay. Do you think that the racial disparities you talked about are linked to other health disparities, such as people of color not going to doctors because of cultural or social stigmas?
So, I mean, the main thing that we are seeing with respect to racial ethnic disparities in COVID-19 are that they seem to be in line with many of the existing health disparities that we're used to seeing in the United States. Although with COVID-19, they seem to be exacerbated a bit. They seem to be made larger, both in terms of the scope of infections and the consequences of those. And those can be, the source of those differences could be myriad. And honestly, I don't think we have science to be able to answer those questions yet. But the linkages between things like discrimination and the role that that leads to getting into a test early, that leads to being able to be treated quickly, is something that we know how that cascade works, detrimental to particularly African Americans in the US or other populations. And we're seeing a similar pattern made even worse with respect to COVID-19. So I don't want to speculate to the specifics of how it's working out and why that's happening that way for COVID-19, but there's decades of literature showing the way that kind of discrimination and healthcare utilization, et cetera, serve to kind of exacerbate health disparities along racial lines. And they seem to be working, unfortunately, exactly as we would have expected on COVID-19, except, like I said, on a slightly larger scale.
I'll just give a follow-up. I mean, do you have a sense of their regional differences in the way those disparities are working with COVID?
Yeah, that's an important question that unfortunately, like, I haven't really had the time to pay attention to because of my work's been focused primarily on Colorado. But yeah, I mean, we would have every reason to suspect that that would be the way it would work. But exactly kind of what they look like, I don't have good evidence for.
Okay. All right. So in many places, including Colorado, people are encouraged to get a diagnostic test if they've been in contact with someone who has tested positive. I see from your testing graph that the diagnostic test is less sensitive prior to the development of symptoms. So how reliable or helpful is it really for someone to get tested who doesn't have symptoms but has been near an infected person? Is there an optimal number of days to wait between having a known contact with an infected person and getting tested?
Yeah, I think this is a really important question. And unfortunately, before I answer it, I'm going to actually make it a little bit worse than the questioner than the question raises. And that is the viral load for people with COVID-19 and therefore their expected infectiousness actually appears to peak just before symptom onset. So once symptoms develop, people are already on the decline in how infectious they are. They're still infectious, but they were more infectious before symptoms. We seem to believe that, from the current accumulated evidence, we seem to believe that the infectiousness peaks right at the development of symptoms or just before it. So yes, knowing kind of how exposure matters and how that translates into tests is important. This is why testing, so I'm going to kind of sidestep the question for a second and then I'll come back to it. And sidestep it by saying this is why when people are, when we know that people have come in contact with a confirmed case, the first recommendation is isolation, right? It's not testing first because the test may not immediately show up a positive transmission and that you yourself are infected or infectious. And so the isolation allows for protection of others from your potentially passing it on to others before you would be able to test positive, right? So that's the first thing is testing and isolation go hand in hand. Testing is not kind of a solution in and of itself. It's something that helps us with other things. Now to the actual question of kind of the delay for testing. We're still working out the details on that, and that's what that slide was meant to show, is that we don't fully kind of know exactly when a test would show up positive because people have variations in kind of their immunity and their kind of physiology and how that will lead to when they become infectious and when symptoms onset for them. So the current recommendations seem to suggest that that delay helps. And that's why often we're having kind of dual tests, right? So a test to confirm a positive and then a test later to confirm kind of that you're no longer infectious or no longer a diagnostic test no longer shows up. But some days are necessary before, from contact with somebody who's susceptible and infectious, before you yourself would be able to show up positive on a diagnostic test. What that number of days is uncertain,
Right.
but it is days, not weeks. It is the version of the answer we can give.
It's tricky. Yeah.
Very.
So how does the likelihood of misinformation find its way into the academic literature and not just into the public dissemination of that information? And what are the consequences of that for our response to COVID-19?
So, yeah, I mean, this COVID-19 is something that we are learning a lot about very quickly, is the first thing I would say. And so as a result of that, the way our knowledge base is building is also happening very rapidly. And so in the kind of scientific realm, we're relying a lot on what are known as preprints. These are papers that haven't gone through the peer review process yet, so they're not published in journals. And we're doing that because we're having to build a knowledge base kind of as we go. And so there's a lot out there, and some of that is going to be reliable and some of it's going to have limitations. And so we have to learn based on, one of the points I was making earlier is we have to learn based on the accumulation of evidence rather than relying on any one source. So we look for kind of how things start to aggregate and show kind of similar patterns across multiple studies. The second thing I would say is some examples have come up over the last week about mask wearing, where there was a study last week that was retracted about the efficacy of masks, and then there were two that were kind of noted with some caution about the data in them. And people have raised those as, are these evidence points that we should be concerned about the kind of utility of evidence about masks protection for COVID-19 or for the transmission of SARS-CoV-2? And the answer is, well, no, a single study isn't what we rely on. We rely on the body of evidence. And there are many other studies out there that do show the benefits of masks. And so in a number of ways, something that's potentially counterintuitive to some is when we see papers in science either kind of being withdrawn or being retracted, in a number of ways that's science working properly. We're learning new information as we go, and when that new information comes in and checks something we thought previously, then we update that information and stop relying on the stuff that is no longer seen to be valid.
Right, but there's probably a lag though, right, between what's going on in the academic literature and what's being reported in the press. And the press will kind of run with certain, right?
Unfortunately, we seem to be seeing both sides of, normally there is a lag, right, that academics like to do things slow. We like to take our time. We like to confirm things. And then eventually, you know, on some delay, the media decides that it's interesting and they'll tell you something about what we found. Right now, because of the heightened kind of attention to COVID-19, we're seeing that happen in some places, and then in other places, we're seeing, you know, the media jump out ahead of what the science even says. So the number of times I've seen news stories or magazine articles based solely on a press release and the conclusions from those papers without the paper even being available to anyone, much less having been peer reviewed, for COVID-19 is much larger than it's been for anything else I've ever seen. And so that's like when I'm saying we should vet our sources and we should look for where things are coming from and looking for links to the like data and the actual papers. That like press releases should not be the end of our trust in something. We should be looking for the kind of backing behind of those things. And I won't pick on any studies in particular right now, but there have been quite a few where the press release didn't hold up once the paper actually was made available to the public.
Okay, so how long before we know if stay at home for those over 60, assuming 60% of this age group stays home, is working?
This is like directly from some of our modeling reports. Yeah, the timing on these, there's kind of two answers to that question. One is you have to account for the lag between kind of how social distancing is likely to affect infections, symptoms, hospitalization, et cetera, right? So that cascade matters. And if we're talking, I think the question was hospitalizations was the endpoint, or was it just working in general?
Working in general.
Right. Yeah, so it depends on how you measure working. That's the first thing I would say. For cases, that delay seems to be on order of about 2 weeks. For hospitalizations are really better data to be able to calibrate these things because many cases are still going untested and unidentified. And so we don't know for sure whether or not we're picking all of that up from the case information. So hospitalizations tend to be, I believe the number is about a week after that. I'd want to dive back into the report to make sure that I have that number right, because that's not a part I've been focusing on, but I believe it'd be, a week after that. The second part of that is the fact that when we talk about social distancing. Social distancing affects kind of work via differential rates of exposure. And so what I mean by that is that the kind of the differences that would be observable for protections for groups by age, so over 60 or over 65, right, might not be immediately observable in that kind of 2-week lag that I'm talking about, because the effects could be not because where they're spending their time, but because of where the people that they are coming into contact with are spending their time. So we would need to be able to account for the delay between when those people would have likely exposures and then how they become exposures to those in those particular risk groups. So it could be even longer than that, is what is the short version of what I'm saying. It might not just be a 2-week lag before we'd see those effects. For some of them, we would expect it to be effectively 2 to 3 weeks even after that.
Okay, so
and it really depends on which scenario you're talking about.
Okay, so we have a long question that you may want to look at yourself in the Q&A, but I'll read it out loud. I'm interested in the prevention, spread, and treatment of COVID-19 in prison and detention facilities. For example, I recently attended a town hall for medical and other professionals about known human rights abuse at the ICE Geo Immigrant and Asylum Seeker Detention Facility in Aurora. Medical neglect, including the mismanagement and manipulation of medical records, has been well documented both before and during this pandemic. Can you speak to the related importance and implications of accurate data collection and reporting in these settings that not only affect the immediate health of detainees, but also the contagion factor outside the facility for detention workers, their families, etc.?
Yeah, that's a huge question that we're just starting to see what I would call kind of high quality evidence on what we know about it. And so these kind of clustered outbreaks and what the impacts of them look like, whether they're in prisons or other types of places, is a question that's really hard to get our head around for a variety of reasons. And as far as kind of how like records and reporting and those sorts of things are differential in those populations, I honestly just don't know. Yes, there is evidence on that, but how that is being implicated in COVID-19 is a question that I think it would take a while for us to be able to answer clearly. But the anticipated potential effects of that are well known, right? And so the kind of the rapidity with which infections can spread through densely connected, kind of tight-knit populations like happen in correction facilities or other places are ripe for seeing infections happen, right? So it's somewhere that needs to be paid, that we absolutely have to pay attention to. The weird thing about it is they're hard to predict because what's going on in in something like prison or et cetera is once a disease like COVID-19 gets there, it spreads very rapidly. But the likelihood of its finding its way into these places is very hard to understand when it's likely to happen. And so there's a great paper by a team at Northeastern on what they refer to as super spreader events that talk about this and why it's very hard to predict when it's going to happen, but what we expect to happen when it does is pretty well known. And so the protections that are necessary inside these types of facilities are definitely higher. And then the question raises a really important point, is these aren't isolated places, right? They then are in contact, there are people who work there or are serving there in various ways who are then in contact with communities, that these can seed outbreaks in the community outside of a detention center or something else in ways that are something that we absolutely need to be paying attention to. I'm not sure if I answered that question thoroughly, but because there's a lot in it, but yeah, that's where I'd start.
Okay, so we maybe have time for 2 more questions. Let's see. The Black COVID death rate is far different than the Hispanic death rate. Is the amount of poverty similar for the 2 groups? If so, what other factors are causing Black individuals to die at such high rates compared to other groups?
So there's 2 things I'd say. I was showing Colorado data, And so the big difference between those in Colorado is unique to Colorado, and it actually has different patterns elsewhere. That's the first thing I would say. And secondarily, with respect to Colorado in particular, there is Colorado's African-American population is small, is small enough that it's the comparison of those disparities are probably picking up on predicting from relatively small numbers in a number of ways here. So I would focus on those patterns more broadly than just in Colorado. That was more meant to be an illustrative example rather than kind of the final detail on that. But the questions, so all that to say, I actually don't know about the disparity, whether or not African-American mortality rate is that much higher than amongst Latino. I'd need to look at that more outside of the data that I have, that I paid attention to. But like I said, the thing we do know is that a lot of the kind of disparities in effects that we are seeing are picking up on and exacerbating known and previously observed disparities amongst racial and ethnic lines. I feel like there was a second part to that question, though, that I missed. Was there more to that, or?
What other factors are causing Black individuals to die at such high rates compared to other groups?
Yeah, so this is another place where comorbidities, the role of comorbidities in mortality rates and age distributions in mortality rates are something that we're learning a lot. So comorbidities, other diseases, other conditions that would exacerbate the severity of outcomes here. And the reality is that we know a lot of those comorbidities that are risk factors for COVID-19 are things that African Americans have a higher historical disparity on because of discrimination and because of lack of healthcare utilization because of discriminatory practices that would lead to those exacerbations. So I suspect that many of them are the result of a historical trend that we know a lot about that just are operating through particular comorbidities that are that put people more at risk of severity with respect to COVID-19 in particular.
Well, thank you so much, Dr. Adams. This has really been so informative. I learned a lot. So the final question is that students wanted me to repeat the prompt, and I want to let students know that this prompt is up on the website. So it's not that you just have to hear it from me. You can always go and check on the website, but I will read it one more time. And it is: describe 2 or 3 key potential sources of information about SARS-CoV-2 or COVID-19. Some strategies for identifying and avoiding that misinformation and why it is important to do so. So now that you've heard the lecture, you can see why that is kind of an obvious question, and I wish you success. So we have another lecture on Wednesday this week by Dr. Gabriel Finkelstein on the history of pandemics. So I think that'll follow nicely from this one. And thank you for attending today. And thank you again, Dr. Adams. And we'll see you on Wednesday.
Thanks for having me.
All right. Thanks.